Welcome everybody to our webinar today. I just want to give a warm welcome to our members, partners, and anyone else new to IVI. Thank you again for joining us for this webinar on uncovering the true cost of healthcare, prioritizing patient perspectives. I'm Jason Spangler. I'm the CEO of the Innovation and Value Initiative, or IVI, and we're excited to have this webinar as we kind of kick off this second phase of our economic impacts work. So welcome everybody. Before I provide a brief introduction to IVI and our work, I just want to go over some housekeeping issues. So all attendees are in the listen-only mode. If you do have questions, please submit them using the Q&A feature. I already see a lot of activity in the chat, which is fine, but if you do have specific questions, please use the Q&A function at the bottom of the screen, which is a couple over functions from the chat function. We do continue to encourage you to use the chat as you want to network and connect with us. And to let you know, this webinar is being recorded so that it's available on demand viewing from our webpage in case you need to miss some of this or you want your colleagues to hear about the webinar today. So once this is finished, we will post the recording on the webinar below at our website. So please bookmark that link. I can go to the next slide, Ushma. So again, I'm Jason Spangler, the CEO of IVI. IVI is a nonprofit research organization, for those who don't know, that focuses on trying to improve the science and practice and use of patient-centered health technology assessments so that we can do a better job in healthcare and the decision-making around healthcare. And so I'm really looking forward to advancing that today with this webinar. One of the things that you might have noticed in our mission statement is patient-centered HTA and what that means. For those not familiar with HTA, or health technology assessment, it's basically how you analyze clinical and economic value of particular healthcare interventions to see, factors such as cost, safety, efficacy, and see, what value they provide. What's I think unique about a lot of the work that we do is around patient-centered HTA, and I just wanted to briefly define what we mean by that. It's characterized in our minds by three key topics. One is that our core principles of patient centricity, health equity, and transparency are key to any work that's done within HTA. We also, as you can tell from that first statement, second statement of we really believe that it needs to include authentic partnership with patients, that they need to be involved throughout the entire process, that they need to co-lead the process and strategy and governance of the work that's done. And that hasn't been done historically within HTA, and we think that it should be. And then the final part, which we're going to get into a little bit more detail today, is that patient preferences, patient preferred outcomes and goals, lived experience are all important parts and should inform HTA methodology. And so that's one of the things that we try to incorporate in the work that we do. And all three of those are what we think are the most important aspects of patient-centered HTA. There are more aspects as well, but those are the core things that we believe that HTA, to be patient-centered, needs to incorporate. So again, going back to our webinar, we're going to provide an overview of this project that IVI is leading to better understand kind of the financial and other economic burdens that patients and their caregivers experience as a result of conditions they have, the health that they have or the health that they don't have, and the healthcare that they need to get. And what we call this whole area of focus is patient-centered economic impacts. There obviously are other economic impacts besides just healthcare and medical costs, and we're going to be looking into that in a little bit more detail today. So we have a great panel today, and I'll get to them in a second, but they're going to discuss a framework that IVI and Academy Health developed that focused on patient-centered economic impacts. And the framework was aimed to kind of measure a broader range of patient-centered outcomes that included things like financial burdens and economic impacts to patients and caregivers as part of an overall holistic approach to understanding the patient experience in healthcare and when they engage with the healthcare system. So last year, with a PCORI-funded grant, we developed a research framework about how to understand or better understand the full range of economic impacts to patients and their caregivers. And we had a final report that you can find. I think it's going to be in the chat. If not, you can find it on our website. And this work aligned with PCORI's kind of reauthorization that called for an understanding of kind of a fuller range of patient outcomes, including economic impacts. Not only can you look at that, in the link after the webinar, but Melanie Ridley from IVI is going to address some of that in her part of the panel discussion. In follow-up to that work, this year we were awarded another PCORI grant. This one is actually a 2-year engagement award to actually build upon the work that we had done previously and to take something from that framework, that conceptual work that we did, and begin to think about where there are opportunities to integrate that framework or concept into research and into how we measure patient experience. And so that's going to be the focus of this next phase of work and what we're going to talk a little bit about today and focus on for this webinar. And before we do that and get to the panel, I just want to kind of highlight some of the problems that we're trying to address from this overall work so that it kind of underscores why this is so important and significant. So one is, as you can imagine, affordability of medical care. We know that patients are burdened with a lot of medical debt when they encounter the healthcare system with different conditions they have. It continues to rise and be a rising burden for patients and their families. And some statistics show that in the US, 1 in 4 adults has some sort of medical debt because of the economic impact of the conditions they have. And so that's one, important area that we want to try to address. Related to that is there are definitely significant inequities in how this debt impacts patients based on income, language, obviously race and ethnicity. We're obviously doing other work looking at health equity in HTA, but you can imagine the overlap between the affordability around economic impacts and the health equity issues and social disparity issues that are related to that. And so we're going to be addressing some of that as well. And then a third problem that we're looking at is just overall cost of care. We know that cost of care is rising and that is a significant barrier to accessing healthcare. And some of the data out of the Peterson and Kaiser Family Foundation Health System Tracker shows that about 45%, so almost half of Americans are worried about their ability to pay for their medical bills. And so that's an affordability issue, but also a cost of care issue. Also, more than a quarter say that they have delayed care or didn't get health care due to costs. And so that's something obviously significant that we want to address in this work as well. And so those are just some of the major issues that we're going to address, not only in this project, but address on this webinar today. As I mentioned, we have a great panel of discussants that are going to talk about their work and how their work is impactful or will impact kind of the overall economic impacts work that we're looking at, how it's related to that, and the significance of all this work that we're trying to do together and address. And so before I turn it over to the first speaker, just to let you guys know, we, in addition to Kevin Wake, I'll introduce in a second, we have Mary Reed from Kaiser Permanente, and then we have Melanie Ridley, who is the Chief Program and Development Officer here at IVI. So let me turn it over to Kevin. I'll introduce him briefly. So Kevin is, sorry, I'm just finding he is the president. I just want to get the full name of the organization correct, Kevin. So Kevin is the president of the Uriel E. Owens Sickle Cell Disease Association of the Midwest. He's worked obviously in sickle cell, but in this broader area of looking at economic impacts for his career. I'll let him do a more detailed introduction, and then he'll start the discussion, and then we'll move from each of the panelists and then have a time for Q&A at the end. So thank you, Kevin. Over to you.
Thank you, Jason. Again, my name is Kevin Wake, and I'm the president of the Uriel Owens Sickle Cell Disease Association of the Midwest. I'm also the chairman of University Health Patient and Family Advisory Council in Kansas City. But first and foremost, prior to my roles in patient advocacy, I am a 56-year-old patient living with sickle cell disease. And today, I'd just kind of like to share some of my patient journey and help set that stage on uncovering the true cost of healthcare and really prioritizing the patient perspective when we look at healthcare burdens that patients often face in our system today. Next slide, please. So when I think of my medical journey and the journey that my entire family has been faced with over the years, I often reminded of the quote, "Never let a stumble in the road be the end of your journey." And I think that all the stumbles that I've faced throughout my entire life and those experiences that I continue to face make me a stronger person and a stronger advocate for our community. So my journey started in 1969 when I was only 9 months old. My older brother, David, had passed away suddenly at the age of 2.5 years old. And on David's autopsy, it was revealed that he had undiagnosed sickle cell disease and he died from complications of that. A few days after David, his autopsy, I was tested as well for sickle cell disease, and I too had sickle cell disease as a diagnosis. My younger brother, John, was born just 2 years after that, and he was diagnosed with sickle cell as well at birth. So you can say that my parents, unfortunately, beat the genetic odds in a very negative way, and all three of their children were born with sickle cell. Luckily, my mom was trained as a nurse. My dad was a dairy farmer in rural Kansas. And after John was born, mom decided to leave her career to be a full-time caregiver for us kids. And we were blessed to have the family support with our illness. And mom taught us as kids early on in our journey that we needed to be vocal in our healthcare and take an active role, talk to our teachers about what sickle cell was, and speak up and never be ashamed of not feeling well. On top of that, we were also raised to never let sickle cell define who we were. And even with being sick often, we still had chores and responsibility around the farm so that we were raised as normal as possible. When I entered high school, mom asked our provider how she needed to start preparing us kids for college. And despite the discouragement from our providers at that time that we should not go to college due to our sickle cell, mom luckily never accepted that advice. And I did go to college and I got my human biology degree. Now, granted, it took over 6 years for me to get that degree, but I did graduate and I had a very successful career in pharmaceutical sales and management for 23 years. Until 2016, when I had several health complications, including my second stroke, I had to leave my career that I loved to focus on my healthcare. After that, I went through a couple of years of deep depression and other mental health challenges, and I second-guessed my purpose in life. And with the help of my sickle cell provider, I was introduced to a local nonprofit here in Kansas City that provided resources for the sickle cell community, and my advocacy journey began. Next slide. So I added this slide. They always say that a picture is worth 1,000 words. So I just wanted to represent through pictures some of the stops along the journey that I have experienced. First couple of pictures there are me and John. We were a child. And then there is the top center picture that is a family portrait. And that was the last family portrait that was taken where John was present. He passed away in 2003 from complications of his sickle cell at the age of 32. Below that is a machine that I'm very familiar with since 2017 as a way for stroke prevention and better management of my sickle cell. I receive exchange blood transfusions every 6 weeks. And so that machine is what I get to see every 6 weeks in the hospital. And then the final pictures are just pictures of some of my advocacy journey, besides my daily work with the nonprofit here in Kansas City. I am involved with educational awareness programs with various pharmaceutical companies, and I've even started advocating for patients at the state and the national level as well. Next slide. So when you think of the cost of living with sickle cell or really any other medical condition, we often think of those direct medical costs that are really easy to measure. And those can include copays, out-of-pocket expenses, and even some non-covered medical expenses, such as over-the-counter medications. But I'd like to highlight some of the other costs that we don't always think about when we look at healthcare costs and healthcare burden that patients are faced with. And I faced many of these, as did my family. And so I just really want to include some of these. The first one would be the cost burden to the caregiver. You know, I think about we can actually talk about that probably as a total separate section for a whole nother webinar. But for my journey, and I think about how my condition impacted my mom, she gave up her career to be a full-time caregiver, which also meant that she gave up having family health insurance through her job. So mom and dad were faced with actually going out and purchasing health insurance and paying that total premium themselves. And I can tell you that was not inexpensive, given especially that they had 2 children with pre-existing medical conditions. We also lived in the farm on the farm in the country. So that meant that we had to travel over an hour each direction to see our providers. That meant that mom often was finding childcare for myself, my brother. And then we also think about the total travel expenses that they were faced with. And these were even greater when one of us was in the hospital inpatient, because mom needed to stay in Kansas City closer to the hospital to communicate with our providers. Between the 2 of us, we had either appointments or hospital stays nearly every single month during my journey growing up. Next. Think about the educational impact of living with a chronic condition. For me, my educational journey took nearly 2 years longer than what most people take due to the way I needed to manage my sickle cell. That meant additional housing costs, tuition costs, and book expenses. And then there was also that semester that I got sick midway through, and I had to have surgery halfway through the semester. That tuition and those book costs were never fully recouped by my family. So those were out-of-pocket expenses that we were faced with. Next, we think about just the impact on one's career. After working 23 years, I mentioned that my career ended suddenly because of health complications. However, I was a fortunate one. I was a salaried employee, and I had a support system with my supervisors that was great. And they accommodated my need for having time off and having a light duty assigned to me. But when I was younger and I had part-time jobs, I was an hourly employee. And when I missed work because I was sick, I didn't get paid. And I hear this so often from other patients in my advocacy work that I do today, that if they are hourly employees, they are missing work, they're not getting paid. And so being able to pay for their housing, their utilities, their food is often a challenge that they're faced with. And they even sometimes will be dismissed from their job because of missing work so frequently. The next is mental health. That can actually present another healthcare burden for patients. For me, mental health care was covered with my insurance when I was working, and I had really gone to a therapist and had gotten a great relationship developed with my therapist. However, when I changed health insurance, when I left my career, no longer was my therapist covered by my health insurance. So I was faced with making that decision on staying with a provider who really knew my history and understood my challenges in life, and pay for that cost out of pocket, or go to a completely new therapist and start my journey all over again. I decided to stay with the person that was familiar with my care and accept that cost out of pocket. So that is a medical burden that I did not expect. Also, when you look at mental health, that can have a direct impact on your daily productivity, which again goes directly back into that career section that we just previously discussed. And then finally, there are so many other supplemental costs that patients can often be faced with. For me personally, I utilize holistic approaches to my healthcare as a supplement to my management of my sickle cell. I get regular massage therapies after I have pain crises. I get chiropractic care for my hip that is now weak and arthritic after my stroke. And I also receive regular acupuncture treatments. All of these therapies are not covered by insurance and come out of my pocket directly. Next slide. So as I close today, I really want to empower everybody here on the call today with the task of looking at healthcare cost burden with a lens that includes the voice of the patient. I really come to realize that patients hold great power in their healthcare system and that we should approach all aspects of the system with the mentality of nothing about us without us. There's so much great work for patients that are taking place out there. And as we develop more advances, we really need to make sure that we fully understand the challenges that the patient and the community are faced with to make sure that those advances are meaningful to the patients overall. Next slide. So as I close, let's all remember that science is better with patients as partners. Thank you.
Great. Thank you, Kevin, for sharing that story. I think, grounding us today in your patient journey really helps us to see how important a topic this is and why it's so critical to really understand and incorporate the full patient experience when we're talking about value in healthcare. I'm Melanie Ridley, and I am the Chief Program and Development Officer at IVI. I lead patient and stakeholder engagement activities in our health equity portfolio, and I'm part of the team on this project. I'm going to provide an overview of what we've been learning as part of a project in building this better understanding of financial and other economic burdens to patients and caregivers, which we call patient-centered economic impacts. And as Jason mentioned, this project was supported by a PCORI Engagement Award, and along with Academy Health and a really amazing group of patients, caregivers, researchers, and stakeholders worked with us to develop this framework. And next slide. And this work really has been grounded in engagement. And so as part of the process of finding the broadest view of what we're talking about and defining patient-centered economic impacts, we engage patients and stakeholders through a steering committee, through key informant interviews, a multi-stakeholder roundtable discussion, and then brought all of these stakeholders back together last March in a meeting to really work with us in thinking about some of the hard questions, complications, complexities as we think about patient-centered economic impacts, and formalize the framework. And IVI did present the framework last March in a webinar, and we can go to the next slide. And through all of these engagement activities, there was this iterative process coming back to what are we talking about? What are all the things that might be part of patient-centered economic impacts and that experience of patients and caregivers? And I think you can hear from Kevin's story how it weaves throughout that journey. And we really heard that from all of our participants that, when we're talking about economic impacts to patients, it's, a really broad set of areas of focus that we're thinking about from the patient lens, where we're thinking about not only those direct medical costs and other healthcare costs, but what are those social impacts on work, education, jobs, and then certainly the caregiver and family impacts. And all of these parts of the framework point to where there's opportunities to better measure the patient experience and the patient journey. And throughout this process, we heard again and again from our patient and caregiver partners that the patient and caregivers really need to be at the center of this. This has to be viewed through the lens of the patient, and that there's a really broad range of financial burdens that just are not traditionally captured in research. That this is really complex, that the health complexity, that lived experience, the socioeconomic status, health disparities all have intersecting and compounding influence around these economic impacts. That intersectionality of all of the parts of us as people are really need to be, thought of and considered as part of this work, that we have to acknowledge that complexity. And we also heard that factors of time, both compounding time of disease impact over time, and that time spent seeking diagnosis, treatment, navigating the healthcare system, all of these things are really important to consider. And next slide. Along with the framework, the report that was referenced in the link in the chat also talked about some principles for how you um, oh, I'm sorry. I heard you covered this. I'm going to go to the next slide. We're going to talk about some of the principles as you're thinking about this work and using the framework, was that we invite patients, caregivers, and family members to really be part of this from the beginning, co-leads, co-investigators, that this really has to be done with patients in a leadership position. That we start with the whole person. We think about this from the patient lens in the broadest way possible. That complexity of the journey. Health equity was a theme that wove throughout all of our interactions with our patients and stakeholders. And we really have to think about where there's opportunities to count for, acknowledge, and advance health equity throughout this work. And that this framework is really meant to help us clarify some research goals, thinking about how we're understanding the patient experience, and that we use the framework and patient stories to really identify what matters most to patients and where those priorities are. Next slide. So I'm really excited to talk about what's coming next in the next phase of this project. And although the framework is available to help guide researchers and address questions around the patient experience, a lot of questions still remain on how we prioritize economic impacts. Those domains cover a lot of area. So, where do you start? How do you identify some priorities? So this 2-year project is going to help us explore that a little bit. We have 3 sort of main areas of focus in our engagement work around this. One is we've established a steering committee. We've had our first meeting, and it's a really dynamic group. We're very excited about that. We're also bringing together a community advisory board, understanding the importance of having patients really and caregivers drive this work. We're going to have them partner with us on the project. And then we're going to host a series of capacity building workshops that dig into some of those really big, challenging questions that we're facing as we think about this work, what we call those like sticky issues that are going to take some time and some thinking together. And next slide. So over the next 2 years, we're going to host a series of 6 immersive workshops, and we hope to connect patients, researchers, other stakeholders in a collaborative effort to explore where there's opportunities to measure patient-centered economic impacts and how we begin to identify priorities, where some future research investment is needed. So our first workshop will occur in mid-July. And we'll have a second one this year in late fall. Registration will come soon, and we're going to limit participation to about 50 people so we can make it a really engaging experience. And after each workshop, we'll share a learning report that has a summary of the discussion, some of the resources shared, what we're learning, and sharing that as we go. And we really hope to get a diverse range of stakeholders participating. So those that, we want to join us in this work are patients, caregivers with lived experience, the researchers doing this work, whether you're embedded within health services research work, comparative effectiveness research, and other areas, as well as funders, purchasers, policymakers, those who are using some of this research and making decisions. Next slide. So I think at this time, I'm going to say a couple of the topics that we might uh, incorporate in addition to the patient journey mapping that I talked about were, how do we account for time? How do we think about methods and data sources? How do we think about the caregiver burden within this? How stress and uncertainty intersect. So lots to come, and I'm gonna transition now, and Mary is going to talk a little bit about her perspectives on this as a researcher. So thank you.
Thanks, Melanie. Hi, everyone. My name is Mary Reed. I am a health services researcher at Kaiser Permanente's Division of Research in Oakland, California. I really enjoy being part of this process. I've gotten to see little glimpses of the development of this framework, and I've been excited to see how it might be able to be applied in my work going forward. I am also the Data and Methods Chair for Academy Health, the Health Services Professional Association, and I think being able to sort of broadcast more broadly that the framework exists and that we can apply it in our day-to-day work as researchers feels like a very sort of promising outlet for the work. And what I want to do today is sort of walk through how I might think about applying this framework in my own experience as a researcher. I'm going to use telemedicine as an example because it's something I study, but honestly, we don't come into this thinking that all healthcare should be delivered virtually. And I also don't come into this thinking that my work well encapsulates, the richness of the story that Kevin shared or other patients have shared with us. It's really like an example of, as a researcher, how we try to scratch the surface and how I think we can expand the depth and richness of our work through using the patient-centered economic impacts framework. Next slide. So just a tiny bit of context. Like I mentioned, I'm in Oakland, California. I work embedded within a healthcare system that covers San Francisco and Silicon Valley and sort of rural farming communities in the Central Valley of California. It's a large system with 4 million patients, and the sort of case study we're going to walk through today is around real-time scheduled patient-provider telemedicine, namely telephone visits and video visits. But I want you to sort of just leave that in the back of your mind, and that's not the goal to talk about telemedicine. It's really to think through how we work out the best way to study telemedicine use and choices by patients. Next slide. Okay, so again, the sort of frame with which I'm thinking about research in this area is, how do patients make care-seeking decisions for telemedicine? Who chooses what type of visit, when, or why? And one thing I wanted to, as a researcher, we often, the framework is an excellent place to start, but then we sort of think about what are different levels that we can apply it. And so I'm going to give you a snapshot of thinking about very large automated data, a patient survey that we've done, and some patient key quotes that are sort of approach a little bit more of a qualitative snapshot of patients' experiences. Next slide. Okay, so I'm going to start with the very traditional, this is my own paper, the reference is there. Again, ignore the content, but I sort of, as a self-critique, we often start as researchers looking at very traditional demographic characteristics, and they are just plainly not enough, but I'm glad that they're captured in the framework. So what I've done here is show you a figure from one of my papers, but what I'm doing is flagging on the left in the blue portions of the patient-centered economic impacts framework that sort of apply to some of the ways that we've operationalized our own research. So we have a bunch of underlying factors, but that's not enough. Next slide. And then often researchers go to the next step and think about what are the direct medical costs, like Kevin mentioned. We can measure patients' copays and deductibles often, just those direct, charged out-of-pocket costs. But I think that those really, through this experience and hearing patient stories, the experience of building this framework, there are so many more challenging to measure patient indirect costs. And so I'm showing you here a couple that I flagged, like social impacts, like drive time to facilities, which I love that Kevin mentioned were substantial. Non-clinical healthcare costs like parking garages and the costs associated with those. Next slide. And this is, again, just sort of scratching the surface, caregiver and family impact. These first few slides that I've shown you are in a sample of over 2 million patients seeking primary care. So in a very large scale, there's still ways that we can dig a little deeper to try to pick up whether an appointment was made by a family member, which means that, often the family member accompanies the patient, and what those caregiver and family impacts might look like. Next slide. Okay, so that was the sort of giant 2 million patient high-level data. And then here's an example, again, from my own work. Ignore the content, but the reference is there if anyone's interested. Thinking through a patient survey. So here's a place where we talk to 1,000 patients about their care-seeking decisions. Again, in the area of telemedicine, but it's really just an example of any kind of healthcare research that people are doing. I circled in the middle. We asked patients to report their barriers to in-person visits, ways that in-person visits are challenging for them. And I circled in the middle that the copayment / deductible really is middle of the pack. It's not the primary barrier, and researchers often sort of go to that cost because it's very measurable, but there are so many more. So I flagged with those sort of blue arrows some examples of other things like caregiver and family impacts, having to ask a friend or family member to go with you to a clinic, having to take time off work, which affects people's ability to work, and further, not getting paid for those hours that you're spending pursuing healthcare goals, and sort of direct and non-clinical costs like missing other activities or travel time or wait time. So I think applying the framework can help us to think through things, domains that we want to measure as researchers, and sort of check those off using it as a rubric to get us thinking about ways to measure things better. Next slide. And then here's a little bit richer of an example, but again, it just sort of scratches the surface about patient experiences. And I think I have a lot to learn and really value the experience of hearing from patients directly with more depth. But here are some patient reported preferences on healthcare seeking tools. And they kind of map to the framework very nicely too. It gives me helps to inspire me to think about ways I can map the framework to the patient-centered economic framework to the rest of my work. So at the top, non-clinical healthcare costs, patients mentioned, not needing to drive or worry about parking and all the associated costs of that. The third one with the green flag, the patient said, if I can get care with a video or telephone visit, then I don't have to get a babysitter, take young kids in the car with me to a medical facility. And again, that's just a snapshot, but it does remind us of the caregiver and family impacts that we can capture in research more regularly with more attention to this. And then at the bottom, sort of looking at the framework and how it maps to my own work, I thought, oh, shoot, look at that. I don't really have a good measure of the employment and education impact in this specific study subset. So I think, again, it can show us where our blind spots are for us to pursue more thoroughly, the range of patient-centered economic impacts that we haven't seen or pursued in the past. Next slide. Okay, so these are just my reflections sort of on next steps as a researcher. I give you some examples of measures that we have developed over the years, but I'm really looking forward to improving those, essentially, to finding deeper and better measures. Researchers could really use help with sort of patient-reported measures, with measures of patient-centered economic impacts at the population or community level. We've played with certain things like rural status of geographic areas. And then clinical data is pervasive. People can study large data sets of clinical care that happens, in the healthcare setting through electronic health records. But again, that has blind spots. And so we need to be creative about how to think about framework domains, the patient-centered economic framework domains in larger clinical data. Next slide. So for me as a researcher, and hopefully for the research community, I think the take-homes about the value of patient partners are really apparent through this work with IVI. I've sort of, it's reinforced just the value of patient partnerships, but also the broader set of stakeholders like policymakers and clinical settings and payers to sort of be at the table together in order to, again, dig deeper, to develop a richer set of patient-centered economic impacts in our work, rather than just sort of out-of-pocket cost, which is a very like crude thing that I think the field has been working from for a long time. I want to also shout out PCORI as a funder of this sort of framework informed research. I think they've been a huge leader in, again, involving patients and stakeholders in the same study, leading a study together, learning from each other. And I hope that other funders will continue to sort of follow PCORI's lead in that direction. Next slide. So I just want to thank my team, and that's just a snapshot, again, of all the people that have been involved in that work and our funder. Thank you.
Thank you guys so much for joining us and for this wonderful conversation. I want to take a moment to invite Mary and Kevin and Melanie to come on to their screens to participate in a discussion period. I also want to invite everybody to participate in a survey that is going to be in the chat function, and then we'll be with you following the webinar today. We are currently asking for feedback from you, our partners, on what are some of the important topics that we want to address in our workshops going forward for the next 2 years. As we said before, our first one is going to be on the patient journey and how to bring that into the framework and how to bring that into research. But the rest are very much up in the air and would really like to hear your feedback. So please do participate in that. Your responses will help inform how we decide the rest of the project. So thank you so much. And again, I want to invite Melanie and Kevin to come up before us and I just want to say thank you again. I think this has been an incredible conversation. My name is Erica DeFermalik. I am the Chief Operating Officer here at IVI, and it has been my incredible pleasure to work with all of you over the last couple of years. And both Mary and Kevin and Melanie have really shown that this whole project, this enterprise, is about how to bring the real experiences of people facing serious health conditions. How do we bring those full range of economic impacts into the research process? As Mary pointed out, it is something people are paying attention to, but it is not easy. And so we definitely want to kind of move forward in that regard. We have had several questions in the Q&A as well as in the chat. So I want to start with you, Mary, just because that one came up first, is that one of the things that we kind of struggle with is that there are sometimes people who respond to surveys and say there's no barriers, and then they still don't show up are able to attend the appointments or their treatment. And how do you resolve that? And is that something that you kind of just say, well, that's just kind of an error, or how do you address that factor around people saying there's no barriers, but they still aren't able to do it? And then kind of building on that is that, have you guys faced anything where there's the other side of the telemedicine challenge where people might use telemedicine, but they are uncomfortable with it. And so then they feel nervous about using the treatment that's being offered.
Yeah, thank you for those questions. I agree completely with the idea that, we might offer a list of barriers on a survey, and it doesn't capture sort of the patient's own personal experience of the barrier that they're facing. And I think, realistically, surveys are a crude tool. We try really hard, but we know that we don't capture all the depth of patients' experiences, and we often leave things off, which is exactly why a framework like this can help us to kind of work through, okay, what are we missing? How can we, be as comprehensive as we can? But yeah, it's kind of it's a challenging task to completely encapsulate the patient's experience there. And I agree. I think that, there can be a variety of mental health or other types of barriers that patients face. In terms of telemedicine barriers themselves, not just in-person visit barriers, but, what do patients perceived to be barriers in the effectiveness or like their own preference for telemedicine. I wasn't able to show you them, but we also try to do that too. So we sort of try to work with patients to think through what are your barriers to an in-person visit, but then what are the barriers to telemedicine? Because it's not, it's not at all a perfect solution there either. And patients have a whole variety of reasons why they might not prefer it. They might not prefer to be on camera. They might not feel the same connection with their provider. And like you said, could affect their sort of clinical outcomes downstream. So we always think of telemedicine as sort of slotting in the mix of a variety of types of healthcare.
Absolutely. Absolutely. And Mary, I really appreciate you kind of highlighting all the different ways the framework can fit in. And I wanted to ask Melanie, just from hearing from Mary, have you heard of other examples of how researchers have been using the framework and what you've been kind of hearing about in the field?
Yeah, we're starting to hear from researchers who have taken a look at the report, looked at the framework, and are beginning to think about where this does fit in with their work. We've heard from a couple that are using it in research planning and supporting grant proposals. So that really very early stage of thinking about their research process, maybe some of their data collection planning. We've heard that in federal efforts in driving value-based care models, informing some of the thinking around how you capture the patient experience and how that informs the design of value-based care models. That's something that we've had conversations related to the framework. And then this work is very much aligned with PCORI's efforts as they develop guidance for researchers in conducting comparative effectiveness research and other patient-centered outcomes research and considering cost outcomes for patients. So those are some of the ways that we've heard this framework is really starting to be thought about and raise some questions. So it's exciting.
That is great. Kevin, I have a question for you, and then I have like a kind of question for everybody. But Kevin, one of the things that has been a major theme that we heard in the first phase was really about how the experience of the social determinants of health, how that can inform our economic impacts, that the economic impacts are not kind of just a flat fee, if you will, that there's really kind of varying experiences. From your perspective as somebody with lived experience, what are some things that you think researchers should really think about when they're doing their best effort, even if they can't quite do it, but their best effort to really account for social determinants of health when they're thinking about patient-centered economic impacts?
Yeah, that's a great question. And I'm so happy that SCOH is being talked about more now. I think as researchers, we sometimes have to meet the patients where they are to really fully understand the community and the experiences that they have. So I think we need to try to eliminate as many barriers as possible to get that patient perspective and just be able to go out in the community and really understand what challenges patients are truly faced with. And if we're doing our research and we're doing it inside the hospital walls, which is one place that many people living with chronic conditions try to avoid with every possible being, is there some other kind of creative way to be able to reach those patients and get their input?
That's great. I think, and I really appreciate that. And that is something that we heard. I know there's a few folks who participated in the first round of this project who are on the call today, and they really emphasized again and again about how this isn't a one and done type of thing, that really when you want to be able to truly understand people's lived experience, it's a long-term relationship. It's about building trust, and it's about understanding people for the long haul, if you will. And that's where you're going to really pull in those insights. I have another question for Kevin, and then I'm going to move to Mary, actually. Can you provide some of your insights on potential solutions that states or federal entities should consider to improve care for people living with sickle cell disease?
I think that is a challenge that we're always faced with, especially as there are new advances that are coming on board, and they have some pretty high sticker prices, and so there needs to be some creative ways that the government can get involved with helping the state Medicaids and Medicare programs really cover some of these programs. I also think that having more of a comprehensive care approach to managing sickle cell once a child ages out of pediatric care and gets into adult care, that is something that we need to have for not only sickle cell, but any kind of person that's living with a chronic condition. We need to have a comprehensive care approach to their management of their disease. And that's not going to occur just overnight. That's something that we need to continue to talk about and talk about how we can actually improve that transition.
I really appreciate that. And, it's something that came up in the first phase where people talked about how that transition moment from somebody who's like on their parents' healthcare and then having to figure out how to get insurance as an adult, having to take a certain job just because it has health insurance, that is an economic impact that is extremely hard to measure, but is important. And that is something, it is a comprehensive care, but it's also just kind of a nuts and bolts of like, how do you just make sure that you don't drop care altogether as you move from childhood to adult or from job to job, if you will. So Mary, you really talked about kind of like you showed, and I loved how you highlighted kind of where you guys were scratching the surface and where this could lead in. Do you have any additional thoughts about kind of ways that we might be able to address, say, like differences in socioeconomic status or differences in health complexity from a patient-centered economic impacts for future projects? Is that something that you've thought about at all, and kind of some suggestions or ideas that you might be able to share?
Yeah, sure. I think I've thought about it. One of the ways that I mean, I hate to, just from my perspective, one of the ways that it's challenging is where to and how to dig deeper. So it would be amazing, to be in a situation where we can really work with patients and understand their sort of their own personal barriers and how that intersects with SDOH measures. Like to imagine a social determinants of health, to imagine a situation where a researcher can really work that all the way through and have ways to measure both things, sort of personal experiences and social determinants of health and clinical outcomes would be sort of a dream research project for someone like me.
Yeah.
I think we'll get there, but yeah, it's challenging to kind of get all the pieces in the same place and be able to really work on it. I mean, it's one of the things I appreciate about the framework that IVI has developed is it sort of helps, but once you have a bit of a roadmap, it can help to shape that research development process.
Absolutely. Absolutely. That's so helpful. And then I guess on a tangent, so Kevin, I guess another question for you is, if you could design your own research study around patient-centered economic impacts, what would be something that you would really kind of want to make sure that would lead on? If you were the co-lead with Mary on a research project, what would be the thing that you would want to make sure that we focused on?
Days. That list would be huge. I think there's so many nuances within a community of patients. Just with sickle cell alone, we're talking about a condition that really impacts a disadvantaged community. And so, like with Mary's project, we're talking about telehealth, and that option oftentimes is not available for those patients.
Right.
So how do we get to those patients and be able to have them actively participate to really understand what kind of economic impacts they have? So we also have to look at, the geographical location of where they are living. I grew up in rural Kansas, and, of course, I grew up in the age I'm old. So I grew up when we didn't have the internet, we didn't have telehealth options. And now we do, but are those truly available for all those patients? I think we need to really look at some of the key things, and that is living expenses, housing, how can they make those ends meet, income, healthcare coverage is another one. So again, there's so many, I could go on and on.
That's great. Thank you. And then we have like only a couple minutes left. So if anybody has any last questions, please put them in the Q&A or in the chat. I wanted to give Melanie a chance just to say if you could just share with everybody what you're most excited about this next phase of our project and where you think that it would be a great opportunity for people to partner with us going forward. And we might put the survey in the link, the chat again for everybody.
Yeah. No, I think, we've heard so much interest about this project, and I think, listening to Kevin today, it's so rich with opportunity in that story that you shared, Kevin, where there are places that your healthcare journey had tremendous impact on your life, on your experience as a patient. And there's so much there. And I just excited to explore how do we really start to take on these big questions, because as Mary said, this is complex, this is hard, and I think that's where these workshops are going to be really exciting to think about. How do we begin to measure this? How do we use mixed methods approaches, pair the qualitative, that patient story, with some more quantitative data or approaches to measurement. And I think that's just, it's a new area, and there's lots of opportunity ahead. So I'm excited for it.
Thank you. Thank you so much, Mary. And I want to say a special thank you to Mary and Kevin, especially. And I also want to call out somebody who's in the background. I want to call out Ushma Patel. She is our the leader of this project this time. She's been managing everything from the background, but she has done some incredible work in terms of helping us get organized and will be leading this project. Thank you so much for being with us today. We hope that we will continue to partner with all of you going forward. If you want to learn more about IVI or the project, please do reach out to us, and we will hopefully see you again very soon. So thank you so much and have a great day.